Please welcome Patrick Runnels, Chief Medical Officer at Population Health, Stathis Antoniadis, President at UH Cleveland Medical Center, and Claudia Douglas, Principal and National Healthcare Growth Leader at Grant Thornton.
Good morning. We're excited to see everyone today, and we're delighted to be asked to be your opening keynote. The whole conference is about collaboration, and I can't think of a better example to start out than to talk to university hospitals about what they've been doing over the past 5 or 6 years in their transformation. I will have to share Dr. Peter Pronovost. He's on the PCAST committee, and yesterday was World Patient Safety Day, and he was presenting at that and wasn't able to make it here this morning. And the best thing is, though, when you can't have Dr. Pronovost, he sent his 2 best people at university hospitals that have been working on this model with him for years. And we're going to talk about how this model is different and go through that today. So with that, I think you heard, we have Dr. Pat Runnels. He's been at UH for a long time and actually was there before Peter arrived in 2018. And very quickly, Peter met him at a meeting and took him to coffee and said, hey, would you like to be in Pop Health and be a chief medical officer with me? And so Pat jumped on board, and they've been working together for 6 years, and he'll be talking about the Believe, Belong, Build pathway to proven performance. And that's the what, and the how is living and leading with love. And then Stathis is gonna be talking with us. He runs their 1,200-bed large AMC, and he was in Boston for a long time. He'll tell you a little bit about that. But he joined a couple years ago, and he's gonna be talking about the practical reality of how do you really implement this? What are some of the bumps in the road? Because it's not always perfect. How do you overcome those? And how this is different. So with that, I would like to add, I've been working with this group for 4 years, and I've been in healthcare for 30. I've spent half my career in health systems. I was a chief operating officer for 8 years. I was a strategy leader twice, all in the Southeast, interestingly enough. And I've also been at 3 Big 4 consultancies before joining Grant Thornton. And I have seen a lot of transformation models, and I'm excited to talk about this for the next 30 some odd minutes, because it is different. It brings a lot of leadership, training, cultural transformation to what we've historically called performance improvement. I have worked at for-profit. I spent 10 years in for-profit, and I spent probably about 5 in not-for-profit. And so I've seen kind of both sides of the coin, and I think I've been in models where we were given metrics and data and benchmarking and told, go fix it, go do it. And it was very top down. This model is not that. This model is setting a vision with your teammates, with those closest to the patient and consumer, however you wanna, what terminology you wanna use. And then how do you all together believe in that mission and that vision and that true north? How do you belong together, which I think sometimes is missing in healthcare, and the whole comment about this conference is collaboration. How do we all belong in this ecosystem to help patients? Like, I'm having knee surgery next Friday. How do we belong to make this is the best experience I will have? And we all have to be working as a team to do that. And then how do we build those systems? And another piece is, how do we then keep that? Because I liken it to any goal you might even have as a person. You want to lose 30 pounds, you can lose 30 pounds. How do you keep that off? So how do you do the perform and transform? So we'll talk a little bit about the sustainability and how this model accelerates transformation as well as sustainability or resilience. So with that, I'd like to ask Dr. Pat Runnels. So Pat, tell us a little bit about, you've been there for
16 years that I've been at UH, 5 years with population health and with transformation.
Yeah. And so can you tell us a little bit about, you've been there a long time. Mm-hmm. What's been different the past 6 years? How does the model, like, what are the key components of what you've done? And how do you believe this is different than what you've done in the past?
So we think about process improvement a whole lot, right? We think about making things better and managing processes. And that's embodied by things like Lean, which are really important tools, really important processes. But we think of it as fundamentally different than leading people. So managing processes, leading people. Most health systems I've had connections with, that I've worked with, including our own system traditionally, were pretty good at managing processes. They were pretty good at saying, all right, we've got a metric, and here's the way you're going to go ahead and change that metric. Here's some support to kind of go ahead and change that metric, but go at it, right? Whether or not that made sense to me, whether or not I believed it, whether or not it was what I wanted to be doing, whether or not I had the capabilities, that wasn't what was part of what was going on. It was about, here's a process, here's what we're going to do, and leadership essentially declaring not only what we wanted to do and where we wanted to go, but how we were going to do it. Leading with love. And that love word is something we throw around all the time because we think it matters deeply. We say it, and we say it, and we say it again, and we say it all the time. And if you go to UH, you hear that word all the time. And a lot of people think of love, they think of it as a cheesy word, as a word that is somehow minimizing the incredible difficult work that goes into leading and running a massive healthcare organization in all its complexity. For us, though, love matters, and the reason it's the fulcrum is love is taking our focus and attention away from processes and shifting it back towards people. And really what it's saying, what our love is about, is looking and seeing all the people that we're privileged to lead as the people who are capable of actually executing the changes that need to happen for us to get truly transformational results. Love is believing in them. It is believing they are capable. Love is supporting them instead of carrots and sticks and hoping they get there, right? Love is then a way of essentially creating a culture in which everybody believes that they're supported, and when you do that, they will go out and execute way better results than you would have ever been able to direct them to do. That's the center of it. That's the love piece. To dig into this concept of believe, belong, build, because I was at the system for 16 years, and to be clear, I'm a psychiatrist. My area was homeless outreach psychiatry, very different from where I'm at right now. I loved the work I did, but it was really about the little space I was in, right? That was really where I was at. And university hospitals was a great place to work, but it was a place where I was there primarily to do this thing. Over the last 5 years, we've seen this massive sea change in where healthcare is going, right? There's a tremendous amount of stress and duress that many health systems are under. And the question for us became, well, what are we doing with this? Where are we going? And in the background was this idea of, we can see a world in which the healthcare we deliver is far better than what we're doing right now. In the United States, there's a lot of evidence, and there's a paper that was published to show that we waste $1 trillion a year in healthcare spend that doesn't need to happen. People are admitted and then readmitted for the same diseases over and over again. We often cause more harm than helping patients actually get better and stay better. We're not great at making sure people stay out of hospitals. We're really great when they get in there at executing what we need to do to make them better, but we're bad at that other piece, right? And most of the people in my generation and the generations beneath me, I'm right around 50, that they learned about all the ways we could make things better, but weren't seeing that put into action in the work we were doing. The work we were doing still looked like kind of the way the system was designed 50 years ago. So when you get to believe, belong, build, the first thing about believe, and I want to highlight two things about that. Believe is setting a North Star, a vision for where we're going. And at UH, that vision was very simply creating the highest value care possible, not just to help people get better, to move away from healing in hospitals and towards staying healthy at home. That was kind of the North Star. And once we set that, that's awesome. You set this thing and everyone's like, yeah, I kind of get that, I'm there. But the second thing that goes into believe is believing that your leadership will stick with it. It's believing that your leadership will back you when you have to do difficult work, when you have to take a project that someone in the past might have wanted to execute it in 3 months and it's going to take 2 years. Believing is believing that they're going to stick with it and they're going to support me, and that even if I fail, they got my back if I was doing the work that I was supposed to do as best as I could. Those two things have to go together. It's not unusual for leaders in health systems, ours included, to declare a big objective and say, we're going to do something awesome. And then 3 months later, 6 months later, 10 months later, that somehow has been pushed off to the side because it's a new shiny object. All the while, all that was really happening was we were managing our VUs just a little bit differently than we had always been managing them, right? So believe is the persistence. Believe is the leaders actually mean it. They're walking the walk and they're doing it over time, right? Then
They're authentic.
They're authentic, right? And they're authentic consistently, right? There's not the sense that it's waving in the wind. There's not the sense that it's going to go away. The belong is a separate thing. So I'm a psychiatrist. There are any number of different clinicians and administrative folks that support the clinical work within our system, right? So many of us felt like we were there to do our little thing in our little space, right? Belong is about, if we're here to provide the highest value possible care, if we're here to keep you healthy at home rather than healing in hospitals, that means everyone is part of that. Belong is making sure that everyone feels like they have a place at the table, that they have a voice, and that their voice is heard and respected, and that they're going to be part of building the solution. Belong is also, and this is really, really important, belong is also making sure that I'm not just in my little silo. Belong is creating connections between silos so that people who otherwise wouldn't work together start to work together. And the belong part, the hard part about that, is that that's not how people have worked in most healthcare systems. Most healthcare systems that I've witnessed, that I've seen, people have their silos and they're comfortable in their silos, they're used to their silos, and they are actually not primed to work and just go across and start grabbing people in places they're not familiar with or they're used to and pulling them into work groups, right? That's not typical. So belong is about kind of saying, no, what do you need to get done? If I'm setting the direction we're going, whether that's reducing readmissions or reducing length of stay or getting annual wellness visits up in primary care, whatever that is, I'm setting that, I'm saying that's where you're going, but we want you to actually come up with ideas about how to get there, and we want you to go find the other people in the system and just start working with them. We don't need to be there micromanaging you.
And if I may, if Peter were here, he would talk about his favorite thing every Tuesday at 8 a.m. is the clinical transformation call. And it was called the clinical transformation call for a long time. And then about 2 years ago, maybe a year ago, I don't know if any of you like an author that wrote a book called How to Know a Person, and he talks about illuminators. So we changed the name of the call to the Illuminators Call.
So every week, we get together for an hour and just share all the great work we've done, and we do that by having the people who actually figured it out present together. Once you get that...
How many people join that call?
Oh, it's at 150 to 200 every Tuesday, and that's a rotating group that's actually about 700 or 800 people now throughout our system that jump on that call with some regularity. When you do that, first, it's clumsy. When you try to get people to belong at first, it doesn't go well. They're confused, they argue, they feel, their instinct is to go up to the hierarchy when there's friction and ask their boss to make someone do a thing, right? That's a common thing. Once they get it though, they move on, and it's awesome.
Well, and the Illuminators Call, having been a consultant for 15 years, is very different. It starts out with a well-being moment, a meditation sometimes. Music is on for the first 10 minutes before it starts if you dial in early, like motivational music. It activates a different part of your brain, a creative part of your brain. Healthcare's tough. Healthcare's scientific. We're dealing with life and death. When we bring that love, that is the love. The music of it, the well-being moment, it is different. And anyway.
Yeah. No, and so they belong. Then we have the build part of it. And the build sounds, most systems, we execute project management really good, right? Okay, we can do that. If we want to improve our productivity, if we want to cut costs, we know how to do that. That's not necessarily quite right as far as we're concerned. Building is having a management system that allows people to move through transformation effectively. The core is having a system that allows you to identify where you're going, what's the thing we're trying to do, and how we're going to get there. We picked the Objectives and Key Results framework as the way we were going to frame how we were doing this so that everyone was incredibly clear from C-suite from board to bedside, is how Peter talks about that, from the C-suite down to the frontline clinicians. Everyone was very clear about exactly what we were trying to do and exactly how we're going to do it. Everyone was clear about what those metrics were. And it was a framework for us to also say, we're going to try to push a little harder, a little further, and that's okay. Our health system, like many health systems, were a little afraid of declaring goals that we might not get to, because we were often incentivized and bonused and whatever that looked like based on hitting our results, right? And we had to slowly get people, no, we're trying to break through things a little, and that means we want you to try and we want to shoot for something, and it's okay if you fail. And having that management framework that people could come back to, that consistently helped people understand, that building part was really huge. Now, we had to get data going, we had to get a lot of other things built, but that core piece mattered. Those three ingredients, you have to have those consistently all the time, and you have to be able to come back and toggle between those different pieces and parts with some facility so that people see that all of those things matter, they start to get the ingredients, and that's when transformational results happen.
Thanks, Dr. Reynolds. So Stathis, you left Massachusetts and you were at two big organizations, Mass General and Lahey, and you came 2 years ago. What attracted you to UH? And you obviously are running the mothership, right? And that is a big challenge. And tough stuff happens at the mothership, right? And you see everything at an accelerated level. So tell us a little bit about some of the good parts of the model and some of the opportunities you've seen as you implemented it.
So one of the main reasons I left Massachusetts after over 30 years was because I was genuinely inspired by the opportunity to do this kind of work at scale. So what we had accomplished at Lahey was great and really changed the culture and anchored it to sort of the concepts of servant leadership. But it was a single organization, and the ability to do it across a $6 billion system with 21 sort of hospital sites was the draw, specific to Cleveland Medical Center. And I do apologize for those I can't see behind the podium. I'll try to shift a little back and forth. You know, the board was very clear when they recruited me. The organization had lost its way, didn't have a clear strategic direction, had continued to slide from a quality and safety perspective, and efficiency was very much not where the organization needed to be able to provide access to both high-level tertiary coronary patients, but also serve as a safety net hospital in the community. So how does all this come together, right? I mean, CMC is a $2.5 billion operation, and here we are talking about love, and people want to see results, right? And I get that. It's difficult. I have to start there. It's difficult. There's a lot of cynicism when you try to change the lexicon from sort of strict management lexicon to one that speaks more to what people immediately perceive as emotions and feelings. But what you're really getting to is belonging, connectedness, and the ability to really engage in a way that will drive accelerated and sustainable results. So let me give you a few examples, or as many as Claudia will allow me. When I arrived at Cleveland Medical Center, again, we are the regional national referral center, and in our ORs, not more than 57% of our minutes were dedicated to inpatient. So we were doing a lot of minor surgeries, and you know, you would ask the question, why is this happening? And no one would really have a clear answer. So how does this model work? Well, the model starts with leadership taking ownership of the outcome that is undesirable and presenting themselves in front of the key stakeholders, in this case, close to 200 caregivers in the OR, owning the failure and having to demonstrate some courage around why we failed and how we're going to engage everybody there to move to a different direction. And again, not everyone's on board. Pat spoke to this. But the ability to demonstrate that there is shared accountability, that it is safe for them to take risks, to make decisions that will not always drive to the desired outcome, but be able to come back, course correct, measure through our OKRs, We're now at 90% of our minutes in our main ORs being inpatient and really focused in the highest acuity surgery. The result has been transformational financially. It has been transformational from a CMI perspective, and also is driving access for very vulnerable populations to those services that they need, right? Advanced cardiovascular, neurosurgical, cancer, transplant, all those things that many of you do in the room. Another example, which was a very challenging situation, was length of stay, right? I don't think there's anyone in the room here who has solved for length of stay. The traditional approach is, you'll sort of set a goal and you say, we need to reduce length of stay by X, Y, or Z, and off to the races, go do it. The idea of belonging became critical to how we approached the length of stay reduction work. We took a very hard look at our organization, and we basically created what we call micro-hospitals. We wanted to do that for the purposes of making it possible to bring people together and give them the ownership for the results that we want to see. Again, sounds simple in concept, but it takes a lot of discipline to execute and to keep people aligned to the targets. But where we are now, we've seen a 14% reduction in our ODE. We are squarely at the median of MedPAR database. We were well over the 75th, and our goal is to get to the top 10th percentile. I'm certain there are many in the audience who deal with similar issues, but we have seen results. And every time we achieve these results, it helps us to further break down some of the barriers to adopting the Believe, Belong, Build model and leading with love. It really is about trusting each other and holding each other accountable in a way that the other models really haven't allowed us to do. But there's incredible discipline, and we have PMs and process improvement teams supporting all of these individuals. We practice lean and other techniques, so you don't discard all of that, right? But it augments it, the effect, and it does accelerate the effect. We went live on Epic last October. Sure, many of you have been through that experience. This was my third experience, and reliably, for the first 3 to 4 months, you have no idea what's happening in the organization. So a lot of the progress we had made just went away, right? Your instrument cluster is dead. You don't know what's going on. And within 6 months, we were able to get back to and better than our pre-Epic baseline. The reason we could see those accelerated results is because we have teams that are now wired. They have that muscle memory to come back together, do the hard work, and deliver the results.
That's awesome. Thank you so much. And I witnessed that, and I haven't seen an organization come back so fast from a full go live in 21 hospitals, and it was truly because the culture is different. I believe that in my heart. So Pat, can you talk to us about some of the, and obviously Stathis also, he was talking about some of the OR for the whole system. He's over all of the, the ORs, very important part in the organization. Pat, can you tell us about some of your in Pop Health? You talked a lot about keeping people healthy at home rather than healing in the hospital. You've had feet in 2 canoes for some time. Can you talk about some of those ACO results and the other system quality experience?
Yeah, I'm going to dig into 2 examples of where we started. We actually, in the primary care side, we got very interested in getting annual wellness visits up. For those of you who aren't doing a lot of the work on the primary care side, annual wellness visits is a code in which you pull people in, particularly for Medicare, and get the general checkup. This isn't this isn't targeted around specific complaint. This is getting you in and just doing your checkup, your tune-up. And it's what allows you to hit a lot of your quality metrics. If you do annual wellness visits, that's where you get in and make sure people have all their screenings ordered, identify stuff that wasn't on their list, but we want to make sure isn't going on, make sure that if they have chronic diseases, those chronic diseases are managed correctly, so on and so forth. When I started, our annual wellness visit rate was around 15%. Around 15% of folks in our system got annual wellness visits. So clearly that wasn't great because that means many, many people weren't getting all the screenings they needed. The approach that the leadership of primary care had undertaken, which was kind of consistent with where they had been, was there's people that aren't hitting the metric. There's people that aren't doing what we want them to do. We need to institute a disciplinary kind of ladder, right? If you don't hit this, then this is what happens. If you don't hit this, this is what happens. If you then don't hit this, you're on some kind of action plan, so on and so forth. It was a stick approach. It was a punitive approach, right, if you're not doing well. Leading with love is shared accountability. You talked about that. It is about saying, first, I believe deeply in everyone's capability. And in starting there, that meant for the annual wellness visit thing, the very first thing we had to make sure was, do we communicate really well what the expectation was? Do people know what the expectation is? And we discovered, as it turns out, that the vast majority of primary care docs didn't actually know there was an expectation. They just didn't know. So we had said it somewhere and had in our heads, we put an email out there, clearly we put the email out there, that's on them. Here's the reality, people get a lot of emails and they don't process everything, right? Most people didn't know what the expectation was. So thing number one, let's make sure we've done our job as leaders and make sure people know what is expected of them. Thing number two, okay, if they know what's expected of them, are they capable of executing what's expected of them? Do they have the resources? So we then went around to everybody and said, okay, we're asking you to do annual wellness visits. Tell us about whether or not that can happen. Tell us about the barriers. And it turned out many people could do stuff, but there were lots of really reasonable reasons why they weren't doing them, right? And as we went around, what we heard allowed us to then say, oh, well, what if we changed this? Or what if we had this kind of schedule working with you? Or what if we made sure the visits looked like this or changed this template or got you an extra staff member, right? All those things played into it. So we first had to make sure they knew what we were talking about. Then we had to make sure they had the capabilities. Then we had to make sure they agreed and concurred with what was going on, because if they didn't buy what we were saying, that's again on us, right? Then, when all those things weren't there, you share results and make sure they know where they are. So do you know where you're at? Do you know where you're going? Because most people believed they were doing much better work than they were, right? They thought they were hitting results they weren't. That's the management system part. That's what we did before any disciplinary action. We executed each of those things in sequence, and we went from having 14% annual wellness visits to 75% in about a 2-year period. That's a huge change, and we didn't discipline anybody to get to that number. At the end of that process, let me rephrase that, that was all without much discipline. At the end of the process, when we did all those things, we were left with, out of 400 primary care providers, roughly 10 who weren't hitting the metric or weren't hitting our results to get there, and that resulted in one person leaving who just didn't want to do the work. But they self-selected out. We didn't discipline them at all. They said, that's not what I want. They were able to make that decision because we were clear, made sure they understood what was going on, and made sure that we were all aligned on what they would need to do that, right? We've done that for a number of processes. We've improved our blood pressure control from around 65 to around 75% for our population. We've improved our diabetic beta control from around 66% to around 83%. We have improved our breast cancer screening by 20 points, up to 81% now. We've improved colorectal cancer screening by 25 points, up to about 75% now. We have, and all those things have built upon each other. They're all kind of in the same. We did the annual wellness visit thing first, then we brought the same teams back together to then hit those other metrics, right? And here's the thing from the overall perspective. Those are the individual quality metrics. Our quality score has gone up. We're doing real well with that. We feel good about that. Our shared savings, 5 years ago when we started, our shared savings, we got one contract. It was our MSSP, and we got about $10 million. We felt pretty good about that. It was $10 million extra bucks, great. Over the last 5 years, we have generated around $150 to $175 million of shared savings that has steadily increased. Our Medicare shared savings was about 10, 11 million. The rest of our contracts have gone from roughly 1 million to roughly 37 to 38 million, and we haven't even gotten our results back for 23 yet. That's a 5-year improvement. It is now because, in our last year's results, we did $50 million of shared savings incentives. All of which is to say, we've gone from it being something that couldn't possibly sustain very much to now being a substantial part of what we do. When people in our system hear those numbers, it becomes a proof point that helps them believe that that change is possible. That is a big deal. And once people see it, once they get a taste of, holy cats, we did 50 million this year, that's pretty good, right? Once they get that taste, they're in. They'll lose faith if you don't keep coming back. We got accelerated results, but then we sustained it. We kept going. Last thing I'll say, and I just, on this point, Stath has got to something that matters. You have to be able to pull people together, allow them to be in a space where they're vulnerable. Vulnerability starts with leaders. Most people are afraid to admit that they're wrong. That's a bit of a natural human reaction, but also our system's set up to pounce on you if you admit a mistake, right? So leaders, in order to actually really improve and really transform, people have got to be willing to call out that things aren't going well. People have got to be willing to be called out that they're doing something wrong. That's not blame. That's not pointing the finger, which is what people feel like. That's how you get processes better. That's what the Navy SEALs do. That's what Pixar does. That's a lot of really high-performing organizations do. That doesn't happen until leaders go out there and say, here's what I'm getting wrong. That's not going to happen until leaders go out there and say, it's okay for us to have some friction. That's the hard work. It's okay for us to have a little bit of an argument if we're all on the same page and we're all rowing in the same direction. Arguments are what's necessary to make things better. Don't shy away from those, right? That vulnerability is actually key to getting teams believing that, wait, I can actually say something's not right, I can call it out, and that means things will get better.
Thanks. I have one more question because I think we're coming to the end of our time. But with what you just said, I think the piece that you just touched on, Pat, is so important around the leader. You've done a lot of, before we jump to Stathis, how many people have you trained on the model? You do a lot of physician leadership, clinical leadership, administrative leadership training?
Just very briefly, we kind of believed that the leadership training was most big health systems have leadership training programs that touch on, oh, here's a little strategy, here's a little accounting, here's a little finance, here's a little leadership style, that kind of thing. We kind of took that model, shed a lot of stuff out, and spent 24 hours basically over the course of 6 months focused on transformational leadership. What do you need? What skills do you need to do transformational leadership?
To remove the political barriers.
Remove the political barriers, right? We needed that. We trained 10 people in our pilot program last year. We have 20 folks in that this year, and we intend to train 20 to 50 physicians and director, VP level individuals in our system.
And you're going to scale it more. So with that, Stathis, can you tell us, because you came with a team, and we just talked about how you overcome some of the barriers. Can you tell us, and I think maybe Russ and Mark will let us go a little bit past that 1 minute.
I think the timer skipped a few minutes.
Yeah, it skipped a few minutes. We had 5 minutes.
That's what I was
You
looking at.
did say we can
too.
have 5 more minutes.
I'm sorry.
No, go
Clay.
ahead.
No,
You
no.
could say, I think we can go about 5 more minutes.
Can you repeat the question, Claudia?
Yes, sure. So with what Pat was just talking about, I found people want to do the right thing. None of us went into healthcare to hurt someone or to other someone, right? We went into healthcare to help people. But sometimes we're in the middle of something and there's a political barrier and we get stuck. And so with what you've been doing with the model, how do you take out some of those politics? And what have you seen about the composition of your leadership team over the past couple of years?
Yeah, so I am going to ignore the timer because I don't have enough time to answer that.
Can we have 5 minutes, Russ? And Mark?
So we've touched on this quite a bit. The model sounds very soft, but in fact, it's very hard. It's a very difficult model to adopt, and it requires a very high level of discipline. It also sets very high standards, and if I have seconds, I'll sort of speak to that. To be brief, some of the leaders were very comfortable with the believe belong component of the model, right? They're sort of wired in a certain way, and some people were very comfortable, and the leading with love, and some people were very comfortable with the build, the discipline, the OKRs. And we fundamentally believe that both components are teachable, and this is the comment that Pat was just making. And we don't have enough time to talk about sort of how do you teach character and how do you teach management systems. And Pat mentioned, people self-select. We've had over 50% turnover in some key leadership positions. And you have to be prepared for that. You have to be prepared for that because that positions you for success. And it's not that these were bad people, it's just that they couldn't adapt at the pace that we set as an expectation. Because we set very high expectations. Earlier, when I was speaking about the OR, there was something I did want to mention that I forgot. So I oversee around 156 ORs across the health system and our procedural spaces. When we went live with Epic, right, we're trying to decide what are we going to focus on, right? Because now Epic sort of gives you a lot of information. We decided that staff time room utilization was critically important for obvious reasons, not enough labor. If you're going to put labor, if you're going to put people in the rooms, you got to make certain you use them. The first output was we are at 51% across the system. Working in this model, working in this culture, allowed us to set some very, very aggressive goals. Very aggressive goals. We said by the end of the first quarter, we're going to be at 70%, second quarter, 75%, third quarter, 80%. By the end of the year, we're going to be at 85% staff time utilization. We have exceeded those goals every single quarter. So we were well ahead of 80% before the month of September will close. And this is not a model about being soft and kind and shy about challenging your team. We set very formidable challenges and we challenge ourselves, but it creates the ability to get to the result because you've got everyone's buy-in. Where you don't have buy-in, you have the right space and the right culture to have the conversations of why people struggle. And you're able to bring them along and ultimately deliver. I will stop there.
With that, thank you. I would say the key thing here are the core values. And I think everyone, if you walk through UH and you feel it, I am humble, curious, and compassionate. I respect others, myself, and my community. And I strive to continuously improve. So I think to encapsulate the model, I think those are some of the key values that underpin it. There's a lot of other things that we can share after the conference and are happy to do that. And we'll be around later if you want to ask more. Thank you. Thank you, Pat.
Thank you.
And Stathis.